afternoon. I thank the organizing team, GVK sir, for giving this opportunity. Also thank Muruganathan sir for giving a wonderful platform for sleep as in one of the title. So my talk of the day is sleep and diabetes. So we as a treating physicians, whenever any patients comes with a good diabetes control, when they loses the control in the due course of time, we focus on the diet and exercise. But we know we won't give much importance for the sleep as one of the parameter that can worsen the diabetes. What is sleep? Sleep is a process, physiological process, where many hormones are down-regulated and few hormones are up-regulated to make the metabolisms very active. What is the impact of sleep on diabetes will be the talk. So it is one of the missing vital sign in the management of type 2 DM. The sleep and diabetes is low quality sleep, there's fragmented sleep or the sleep interrupted sleep can increase the incidence of type 2 DM. In people with diabetes, if the sleep is not proper, it can increase the HbA1cs. And many of the guidelines doesn't support the sleep as to be taken as one of the parameter to be for diabetes control. Now, ADA and ESC have given a clear concurrence. It has to be incorporated as one of the tool along diet and physical activity as a 24-hour movement behavior. And many of the trials, even though sleep occupies most of the day, most of the time of the day, it is the representation in the clinical trials is very, very, very low. That is the saddest, but there is a blind spot. So India never sleeps, but it is at risk of the metabolic cost. This is a satellite picture where India is very active in even the night. It shows the high burden of diabetes in India. Well, what is the metabolic clock? So we have a metabolic clock. There are awake, we had a feeding behavior where there is more insulin secretions and there is also more insulin sensitivity. When you go for sleep, falling asleep is a state of fasting where melatonin is increased, gluconeogenesis happens, is a controlled manner, and also mitochondrial repair happens. The cells goes for repair and regeneration only during the night. So metabolism is not a constant, it's a time dependent and rhythm driven. And what is the role of central nervous system in the sleeps? Whenever you get activations, the stimuli, based upon the stimuli, your suprachiasmatic nucleus is activated. When there is a night focus, the suprachiasmatic nucleus is activated, it throws more melatonin, it induces a sleep and makes the cells to go for repair. If you focus on the light, artificial light at night can activate that orexin, which makes you active even the night, that is going to damage your cells, not the repair. And this is a stage of sleep. I don't want to go for all the stages of sleep. I want to focus only on the stage, on non-REM stage 3, because here the state, the heart as well as respiration goes down. So we give idle rest for the heart as well as respiration, and also tissue repair, growth and cell regeneration happens. So this is the vital part that is the need of the hour, where we get more rest, the probability of heart rate goes down, respiration goes down, otherwise catabolisms of the energy requirement goes down, and tissue repair and growth and regeneration happens. The REM sleeps, again it's going to activate. So as long as the initial part of the sleep, the non-REM occupies more, and as the end of the sleep durations, the REM is going to be the major counterpart. And what happens, how you are going to link the sleep with the diabetes? 1 week of sleep restrictions can reduce insulin sensitivity by 20 to 25% and increase the cortisol levels that pave way for your diabetes. It is not gene related, it is not diet related. Mere absence of sleep or deprivation of sleep for 1 week can produce more ill effect in terms of glycemic controls. And many of the meta-analysis clearly showed, compared with 7 hours of good quality sleeps, if you decrease each hour, that is less than 6 hours, the risk of diabetes, getting a diabetes is 9%. If you increase the sleep, the risk of getting a diabetes is 14%. So the sleep is declining across the globe. At the same time, diabetes is also increasing. So both the epidemics are biologically synchronization nowadays. These are the meta-analysis. I don't want to focus all the meta-analysis. The incidence of diabetes is increasing when the sleep duration is going down. At the same time, the shift workers, especially high-risk people, the healthcare professionals, IT professionals who are going exposed to shift workers, also the incidence of diabetes increasing because of that. And also diabetes, people who are having fragmented sleep, the HbA1c is increasing. What are the ill effects of short sleep on the cardiovascular and metabolic risk? We know that short sleep as well as long sleep is reducing the glycemic control. The social jet lag is also with higher HbA1c levels, and many cohort analysis clearly alluded that diabetes patients with the disrupted circadian rhythms have high risk of CV events, ischemic heart disease and CV mortality. Is sleep disturbance a cause or a consequence of diabetes? So when you focus on the artificial light at night, your eyes through is activated, the suprachiasmatic nuclei with the retinohypothalamic tract. So usually we had a good melatonin, but presence of light stops the surge of melatonin from the pineal gland. On the other hand, it stimulates more glucocorticoids. So these glucocorticoids disturb the circadian rhythms and disturb the sleep-wake cycle, body temperature cycle and hormone cycle, sets it into pro-thrombotic, pro-inflammatory states. On the other hand, the melatonin is reduced. Melatonin carries more benefit in terms of antioxidant, anti-inflammatory, antihypertensives. So whenever you have a more screen time, whenever you activate your pineal suprachiasmatic gland with the light, you are be subjected to more glucocorticoid levels with reduced melatonin, which is not good for the body. Same things happen in the beta cells also. Beta cells also is a time-dependent secretions. It influenced by many factors. From the gene expressions to the insulin secretions, it has been modulated many key parts like glucose signaling, potassium, calcium handling and cyclic GMP. So it is under time-dependent insulin secretions, is also under the circadian controls. So pathological link is there is a neuroendocrine inflammatory axis sets in if there is insufficient sleeps, make the high surge of glucagon, growth hormone, cortisol and sympathetic adrenal that produce insulin resistance. On the other hand, if there is a reduced sleep, there is more physiological stress to the brain, stimulates more cortisol, more lipolysis. On the other hand, indirectly, whenever you awake, the appetite is very, very high, increased fat, increased insulin resistance, everything in nutshell produces decreased insulin sensitivity. On the other hand, to the hormonal milieu, it also triggers more inflammatory milieux. It is a high surge of interleukin 6 is there, tumor necrosis factor is there, CRP level, all the things also pay attention for the insulin resistance. So, one is inflammatory milieu is very high, sympathetic overactivity is very high, high appetite, high obesity hormones are very, very high. These are the reasons any short sleep fragmentations produces more inflammatory milieux, produces beta cell dysfunction, increase insulin resistance, that in a nutshell produces type 2 DM and this. The circadian disruption is in a hidden diabetes. These are the people, night shift workers, IT professionals, healthcare professionals and factory workers are very, very highly prone to this, and the studies have clearly alluded if they are able to continue, if they are not able to rectify this circadian disruptions, they are able to develop diabetes within 30 to 60% near futures. Next in OSA, it was clearly discussed yesterday by Dr. Perry and we know that OSA is characterized by recurrent hypoxia and sleep fragmentation, and each apneic episodes triggers a stress response, high surge of inflammatory milieu is there, and we know that OSA is highly prevalent diabetes mellitus. And OSA occupies the center state of cardiometabolic triad, so it increases obesity, it produces insulin resistance and poor glycemic control, and also accelerated hypertension because of high sympathetic nervous system activations. And on top of that, it also produces more arrhythmogenic, are more prone for atrial fibrillation and all, and accelerate atherosclerotics. That may be reason for a premature cardiac arrest. Everything it has been triggered by obstructive sleep apneas. And this is a nutshell how it is going to be. The intermittent hypoxia, sleep fragmentations produces more inflammation, more oxidative state, high sympathetic nervous activities, produce insulin resistance and glucose intolerance and type 2 DMs. And 7 in 10 diabetic patients are suffering from OSA, and out of 5, 4 of the obese may have OSA. So it has to be handled. And treating OSA also improves the metabolic outcomes. So it can reduce intermittent hypoxia, reduce sympathetic activation, reduce the cortisol, and increases the insulin secretions or improves the insulin resistance. Thereby HbA1c can be dropped down. Another is insomnia. Many of the patients may complain, I could not able to get a good sleep. All the times I'm hyper also even the night. So what happens, insomnia is entirely different to the OSAs. So a chronic insomnia in type 2 is difficult initiating or maintaining the sleep, and they are noticed by sleep fragmentation on off and under X. Many of the time we won't ask our patients how the sleep pattern, how they are going for sleeps. This results in hyperarousal state, so high sympathetic activities, what we are told before, sleep fragmentation and so on. So in nutshell, the sleep problem, insomnia and everything increases the HbA1c level, and many of the things have associated with the micro and macrovascular complications. So how we are going to assess? So this is the AD consensus. First check how the duration of the sleep. So at least 7 to 9 hours is recommended for the optimal outcomes. You can assess any questionnaire, how the sleep pattern is there. Many questionnaires available on the internet. And next is quality of the sleep. At least efficacy of the sleep should be more than 90%. What is the quality of sleep? How many the sleep duration to the ratio to the falling asleep. So how many the patient having good sleep to the sleep duration has to be taken into consideration. It should be more than 90%. And chronology, the social jet lag should be less than 90%. So this has to be taken into consideration for this. Now how can you validate the sleep in your day-to-day clinic? We can use many tools is there. This is a self-made tool we can tick. Can give to the patients to take them before they comes to your consultations. There are few other well-validated questionnaires available. So quick screen is check how the patient is fall asleep. Ask the patient how they fall asleep, any interruption during the night, and how they feel early morning, they get refreshed, or they have some sort of a headache or some sort of somnolence, daytime somnolence is there or not. These are the few questions you can ask the patient to assess the quality of the sleep. How you're going to intervene? This cognitive behavioral therapy, there is a set of cognitive behavioral therapy inclined for insomnias. Focus on sleep hygiene. So ask the patient to go to sleep at a regular time. Then avoid caffeine or any other neurostimulant drugs before that. Limit the screen exposure. These are the sleep hygiene we have to incorporate with the patients. And stimulus control therapy. Blood should be used for sleep alone. So they should not chat, or they should not watch TV and lying down bed. That can disturb the circadian rhythms and all. And sleep restriction therapy should be there. And cognition therapy, relaxation technique like meditations and yoga can be opted for adequate sleeps. So what are the pharmacological intervention is there? We have melatonin. It is more better than that of sedative drugs. So it has been proven that short-term use of prolonged melatonin has been shown to improve sleep maintenance, sleep quality. But many of the studies shows it reduces insulin secretions, but it has a more pro-inflammatory, reduces the pro-inflammatory pathways. In a nutshell, it protects the beta cells. Even though it reduces insulin secretion, it has a protective effect as like statin. It has a more protective effect on pro-inflammatory pathways that saves the beta cells from the loss. And many meta-analyses clearly alluded that it has a great impact in reducing fasting and insulin sensitivity, but not HbA1c. So take-home messages: sleep is a central component in the management of type 2 diabetes. So pragmatic physician work, check the screen, how the sleep duration of the individual, how is the timing, whether daytime sleepiness is not. Phenotype: early bird is better than the night owl. So short sleep, they are more prone to develop cardiovascular events. Chronotype, that is early to the bed, is better than going for late night workers. And you have to assess the OSA patterns. Target less than at least 7 hours of the sleep should be there. Sleep efficacy should be more than 85%, and jet lag should less be 90%. And track the evidence by HbA1c reduction, and you can use many tools, available tools is there to assess the snoring pattern, to assess the quality of the sleep and all. So wearable metrics is there through the smartphone and all. So the primary duty of the physician is to incorporate sleep into the clinical consultations and ongoing diabetes education. So sleep is not a symptom, it is a therapeutic target in diabetes mellitus. Thank you for the patience.
Thank